So the GALLIUM study was a frontline study for the treatment of follicular lymphoma and marginal zone lymphoma, so the two most common indolent non-Hodgkin lymphomas that we see. And it was a study with the goal of determining whether obinutuzumab in combination with chemotherapy was superior to rituximab in combination with chemotherapy, which is and was at the time the standard frontline treatment for follicular lymphoma in Canada. So the study wanted to allow a number of centers to participate because it was a multi-center, multinational study. So they allowed for a number of different chemotherapy backbone choices, bendamustine, CHOP, or CVP, based on standard of care options at the time. Because we were quite impressed by the data for bendamustine, we were motivated to use bendamustine, and most Canadian centres had the same perspective. But bendamustine wasn't yet funded for indolent non-Hodgkin lymphoma frontline in Canada, so it was another incentive and another desire for patients to participate in the study, because they not only had the chance of getting access to potentially a more effective monoclonal antibody, but in addition they got access to a chemotherapy that wasn't available to them otherwise. So what was interesting about this study, and better than what was done in, let's say, the BRIGHT study, where they compared R-CHOP to R-CHOP, R-CVP, and R-Benda, was that this was a chemotherapy decision for the center. So you had to be willing to put every patient on study onto the same chemotherapy arm. You didn't get to choose individual patients to receive different chemotherapies. So we chose bendamustine at all of the centers in Canada that participated. And because of that, we really thought it was a very good treatment option. So we offered the study to all eligible patients, which we try to do for all studies that were opening at the time. Because of that, we enrolled very rapidly and successfully. So I think we had 49 patients on the study. Edmonton was doing the study at the same time at the Cross Cancer Institute, and they similarly had very successful enrollment, and they actually had a couple more patients than we did, but together Alberta enrolled more patients than any other country in the study, even excluding other Canadian sites. So that's partly why there were two Canadian authors on the paper, both from Alberta. The study obviously was very important, and hopefully one day will become practice changing, because it did demonstrate a longer PFS for the obinutuzumab chemo combination followed by obinutuzumab maintenance compared to the rituximab containing regimens. But obviously with greater efficacy comes slightly increased toxicity, and so particularly there are more infusion-related reactions with obinutuzumab, and that is not a new signal. It's something that was known about before, particularly because we already had access to obinutuzumab in combination with chlorambucil for CLL patients, and we tend to see even more reactions in CLL patients. So I don't think the increase in IRRs is concerning to most people, but there was also slightly higher rates of neutropenia and slightly higher rates of infections, though not significant. So in general, there were more adverse events in the obinutuzumab containing arm, but many of those were IRRs, and they were toxicities that are really, I would say, ones that we are comfortable managing as hematologists. What was surprising and has caused quite a bit of discussion after the study was the difference in toxicities noted between the different chemotherapy arms, which was not really a planned outcome from the study, to be looking at the individual chemo arms for their toxic outcomes. But there was a note of an increased number of non-lymphoma deaths in the chemotherapy arms that contained the bendamustine, both the BR and the obinutuzumab with bendamustine, but mostly the obinutuzumab with bendamustine. So that has caused obviously a lot of discussion, because bendamustine is our frontline treatment option for indolent non-Hodgkin lymphoma pretty much across the country and in many other centers. And so everybody who uses that routinely wants to know whether that's a signal we need to be aware of. And I think it's something that is very important to now pay attention to and to watch for. What is interesting is when you look at the different deaths, the first thing that stands out is there are more infectious deaths, particularly particularly in the obinutuzumab-containing arm. So that warns us that we need to be more vigilant for infections and consider more aggressive prophylaxis to infections with bendamustine. And that we did use a lot of prophylaxis in the relapsed setting, but many of us don't use a lot of prophylaxis for frontline treatment. So I think that that should probably initiate some change in practice there. But otherwise, there was a number of other deaths that were all from completely disparate causes, nothing that suggested a real signal for a drug cause effect, maybe more chance you could question in terms of one neurological, one cardiac, one respiratory, a number of other things that didn't really seem to suggest a real trend. So in general, I would take that my take-home message from the safety is that the obinutuzumab has a little bit more toxicity, but that's quite manageable. From a bendamustine perspective, we should be watching quite closely for infections. So my perspective on the efficacy results is that there was a significant difference between the two groups, with a superior progression-free survival that was really notable with the obinutuzumab chemo followed by obinutuzumab maintenance. So I've heard a lot of people talking about the study afterwards, and I think that the difficulty is understanding the statistics and trusting the statistical interpretation that predicts what the gain in remission would be for that level of a hazard ratio. So the hazard ratio is very strong at 0.68, I think, favoring the obinutuzumab arm, and that's a very marked difference in terms of PFS. However, the follow-up of the study is not long enough that we can actually declare a median PFS in the two arms and to tell an average clinician what the difference is. So at the time of the presentation of the results and the publication of the results, the difference in relapses between the two arms is not that great in terms of absolute numbers. A lot of it is just forecasted because of the difference that is seen statistically. So that difference is statistically significant, and it's clinically very meaningful to have that strong a hazard ratio. But most physicians need to see longer follow-up to actually be able to understand that difference better. The statistical estimate is that it would be about a 3-year advantage in terms of the PFS for the obinutuzumab-containing arm, and if that is proven with time, that is a clinically meaningful difference that I think everybody would accept. But currently, there's a lot of people who mistrust whether that calculation is actually true. And until we actually count the relapses to get to that stage where we're confident of that difference and the exact number of difference in terms of the PFS gain, then I think that it's not going to change our practice very quickly. The other question is about an overall survival advantage, which will be very hard to prove in the short term for follicular lymphoma, which is a disease with a very long natural history and a long time till progression, with additional therapies that are still possible at relapse. So an overall survival advantage could occur, but we won't see that for many years. So I think it's unrealistic to think that we have to wait for an overall survival advantage before we can talk about funding the drug, but I certainly think that we need longer follow-up to have more confidence in the difference and in the advantage, particularly for people to be willing to change practice to include obinutuzumab for all indolent non-Hodgkin lymphoma patients.